Hello, everybody, and welcome back. I hope you enjoyed that amazing video celebrating the phenomenal progress of the All of Us research program. I'm Jeff Ginsberg, the Chief Medical and Scientific Officer and Acting Chief Data Officer for the program. And before we get started with this keynote session, I'd like to cover a few housekeeping items. First is that closed captioning can be turned on by pressing the CC but icon just above the video. If you run into any technical issues or need an accommodation, please email allofuscienceday@pyxispartners.co. To ask a question, please select the Q&A option at the top of your screen, type your question and submit it. Questions submitted through the chat box will not be monitored, so please use the Q&A box. And then finally, I'm pleased to present our keynote speaker, Dr. Pradeep Natarajan, who has been a close colleague and avid supporter of the All of Us research program. He's Director of Preventive Cardiology at Massachusetts General Hospital and a leader in personalized and precision medicine and cardiometabolic disease prevention at the Harvard University and the Broad Institute. Today, Dr. Natarajan will show us his discoveries, how his discoveries are being translated into real-world care. And he'll share how tools like polygenic risk scores are helping us predict disease and move research findings closer to everyday clinical use. Pradeep, the floor is yours.
Thank you so much, Jeff. Very excited to be with you all. So we'll get started. These are my disclosures, not relevant directly to this talk. So this is where I practice. This is Massachusetts General Hospital. It's one of the oldest hospitals in the U.S. Over about 200 years old. You can tell this is not the original entrance, but the buildings over years have come together, so they all have a different feel. We all do carry pagers. As a cardiologist, I do get paged when patients are coming into the emergency room with a heart attack. This is an example of one similar kinds of pages, and you see some of this dramatized in shows like The Pit and others, which are reasonably accurate, at least as it relates to this condition. And heart attacks come in different flavors. Heart attacks can be medical emergencies. STEMI, or ST elevation myocardial infarction, is of the flavor of a medical emergency that requires us to act up pretty promptly. And we see these patients all the time. And that age, I call out 49 years old because that is, an early onset heart attack. The way that we help identify those at risk are looking at things like age, sex, and risk factors to predict the likelihood of risk. And those events that are happening early in life, those are kind of outside the tools where we can accurately identify those at risk. But in medicine, we're really good at this. Patients come in sick. We know how to stabilize, treat the acute illness, and prevent, chronic complications. But what is really hard is to prevent the onset of these conditions before the symptoms manifest. And that obviously can have substantial influence on individuals' lives if we had to do that, if we were able to do that well. Now, this is deaths attributed to cardiovascular disease in the US. These are statistics that the American Heart Association puts out every year. So this is the most recent. On the left side, you see starting in the 20th century, with death from infectious disease decreasing, death from cardiovascular disease became the dominant reason why Americans die, at least for about 100 years, since the 1930s, 1940s. You do see a big inflection point in the middle of the 20th century, really in the latter third of the 20th century. This time's around the time that there was now recognition of risk factors like cholesterol, blood pressure, smoking. In the 1960s, that's when the Surgeon General's report was on tobacco smoking and heart disease and cancer, and a lot of the modern innovations in cardiovascular medicine. Unfortunately, we don't see this curve downtrending, but it's at least not uptrending. Now, cancer is a close second, but it does maintain that dubious distinction of being, the leading killer. Now, our, therapies to treat heart disease remain quite effective, and I argue that a lot of why it's still quite high is that we need to focus more on how we can prevent the onset of heart disease itself. Now, I'm really fortunate to actually also have an outpatient clinical practice in what's called preventive cardiology, where we have a unique focus on trying to identify individuals who might be high risk before they develop cardiovascular disease. To some extent, that is there in internal medicine, but this is a major focus within at least our subspecialty of cardiology. Now, I feature here Dr. Paul Dudley White, who was the founder of our cardiac unit at Mass General over about 100 years ago when cardiology was just being established as its own specialty. Here he is with President Eisenhower when President Eisenhower had a non-fatal heart attack while in office, and was a big proponent of early mobilization after a heart attack, recognition, treatment of risk factors as well too. And so we focus, in this specific practice, but we have a lot of challenges in the current tools. A major reason why folks come to me where they don't fit in the general buckets of risk is when they're younger and they have a family history of heart disease. And we'll talk more about that in a sec. Now, heart disease, at least coronary artery disease, that's plaque buildup, that's the root cause that really leads to a heart attack. That plaque buildup turns out to start quite early in life, well before the onset of symptoms. Now, it's really hard to understand how early that starts. Among the best data that we have comes from US soldiers killed in foreign wars. These are autopsy data from plaque buildup in the coronary arteries and the heart arteries of US soldiers that were killed in Vietnam, Iraq, and Afghanistan. And what you can see here among healthy men and women in their 20s who did not die of cardiovascular disease, who are dying of trauma, a large fraction of them have plaque buildup. 1 in 9 have plaque buildup. But you can see here in the middle that the majority of them who have plaque buildup actually don't have recognizable risk factors. Now, those who smoked, had high blood pressure, high cholesterol, sure, they were more likely to have plaque buildup. But the majority of them, 81% of them, so 4 in 5 had plaque buildup, but they did not yet have recognizable risk factors, indicating that there might be an opportunity to prevent early, but we don't yet know exactly, what those things are outside of those traditional risk factors. Now, this is a great perspective from Dr. White now about 70 years ago, where he was talking about the preceding 400 years of what has been known about cardiovascular medicine. And as he sets the clinical and scientific agenda for the future, he says that things that we now take for granted today, that we use today, the role of the family history, implicit in it is the genetics, that we really need to study this more to understand what are the other reasons why people are getting heart disease so we can identify these individuals. And one thing I find remarkable is that he calls out the term human genetics. And it's remarkable because this was written in 1957. In 1953, just 4 years prior, the structure of DNA was described in a paper by Watson and Crick with critical input from Rosalind Franklin. And so applying that to a common disease was pretty forward thinking. Now, there were some notions that genetics would play a role, with clear molecular insights for cardiovascular disease. What was described as a dermatologic condition of families being enriched for individuals that had xanthomas or cholesterol deposits in their tendons was described in the 1800s. And then a Norwegian physician called Carl Mueller found that these individuals in these families, those who had who had deposits of cholesterol, also seemed to be having cardiovascular disease at young age. And then he also made the observation that they had high cholesterol. Now, enterprising physician scientists Brown and Goldstein, who had, incidentally trained together at Massachusetts General Hospital, met, and then they both did postdoctoral training actually at the NIH in biochemistry and molecular genetics. And they were interested in thinking about inborn errors of metabolism, which would manifest in young kids largely because 2 gene copies were disrupted, but the patterns in this condition, familial hypercholesterolemia, was different. The adverse outcomes would happen later in life, and there was kind of a stepwise gradient. There were some who had, pretty severe high cholesterol and those who had really high cholesterol. And, many years of work from them and others, they uncovered that it was responsible, was a single gene mutation, the LDL receptor. The LDL receptor sits on the liver surface, is responsible for clearing cholesterol from the circulation. But in those individuals, they have disruption in the LDL receptor, and the liver, which is actually responsible for synthesizing cholesterol that circulates and gets delivered to the other cells and tissues in the body, thinks that there's actually not enough cholesterol and it starts overproducing cholesterol. But that was these were foundational studies that helped us learn about the role of LDL cholesterol in cardiovascular disease, emblematic in these exceptional families, but having insights now more broadly. But we know that, heart disease, very common. I showed that before. Increasingly, we see it in younger individuals. And a common observation in younger individuals when it's manifest is, that they often have a family history of cardiovascular disease. This is a nice study that was kind of all the Boston area hospitals collaborating. This is Dr. White along with other collaborators. And they looked at individuals who had early, heart attacks and older controlled individuals who didn't have heart disease. And what they observed were those who, lived long, didn't have heart disease, generally had family members who lived long. This general notion that, genetics may play a role. Now, I'm jumping around timelines a little bit, but, the National Heart Act, which established the National Heart Institute, a precursor to NHLBI, one of the existing National Institutes of Health, that also established the precursor to the All of Us program. That was the Framingham Heart Study. That's about 15 miles from where I am. And that was much smaller in scale, about 5,200 individuals. And that really was critical in the initial observation of risk factors and their roles in cardiovascular disease that made that dramatic change in the 1960s. But one of the things that they also observed, this is work from Dr. Lloyd Jones when he was a trainee at Mass General. He is now actually the overall PI of the Framingham Heart Study as of about a year ago. He and colleagues observed that if you have a family member who had premature cardiovascular disease, independent of the other risk factors, it's about twice as likely that you would develop cardiovascular disease. Okay, so that formed the basis now in parallel with the technological advancements of looking now directly at the DNA sequence variants to understand the extent to which it's DNA, right? Because there are many reasons why family members might have heart disease that might influence you that is not just genetics. Obviously, you share genetics with family members, but oftentimes health literacy, access to foods, education, income, all of these determinants of health are also correlated and influence the likelihood of disease. But these form the basis of saying, okay, let's look at the DNA, the extent to which this is DNA. And this is kind of where the field is. Now there are about 350 different regions of the genome that are linked to the root cause of coronary artery disease. These are now forming the basis of new medicines that are being developed, some of which are already in clinical practice and many of which are pretty far along in their evaluations as well. But we can take also the totality of that information and for the patient in front of us, develop a predictor of risk. In its simplistic form is you take each of those 350 risk regions and say for the patient in front of me, how many of them do they have, right? And that score could be 0 to 350. There are innovative methods that now incorporate many additional variants across the genome, just because many of them we do recognize have risk as the studies get larger and more diverse and we catalog more regions that are influencing coronary artery disease, so we can use statistical methods to recover some of those signals that we know we will get in the future. And the scores are continually improving, okay? So what I'm showing here is a comparison of a score that we developed in 2018 to a score that we developed in 2023. Mind you, the genetics are unchanged. It's our ability to interpret that is improving. And the metric here is the number of individuals, the fraction of individuals that are at particularly high risk. Particularly high risk is risk like familial hypercholesterolemia, that rarer familial condition I told you about earlier. That's 0.5% of individuals in the population. That's about a 3 to 4-fold risk. Now for this test, this so-called polygenic risk score, where we use a broader set of variants, about 1 in 5 individuals has about a 3-fold risk for coronary artery disease. Now, familial hypercholesterolemia, we do have genetic tests for that. You often have a pretty good sense just based on the standard lipids. It turns out by a polygenic risk score, even though these genetic variants often tag pathways that we know, they tag a lot of pathways that we don't know. So those who have a high polygenic risk score, you would not be able to tell based on their traditional risk factors, including like LDL cholesterol. And these improvements for the scores are continually going up. Oftentimes it's because it's a broader set of individuals and it's often a broader set of individuals that haven't been studied before. So we can better look at the combination of variants together, and then we're more confident in what the signals are and how to use them for risk. Now, another feature is, in addition to risk prediction, we want to use these tools to really help us identify who should be getting preventive therapies, right? We can continually refine our crystal balls, but in medicine, like, we want to do that. We want to do these tests if it's going to be helpful for us, helpful for the patients to optimize their health, and not just do tests because we can do tests. Now, today we allocate these preventive therapies by having individuals who have more and more risk factors. If they have more and more risk factors, they're more likely to get cardiovascular disease, so they're more likely to benefit from a preventive therapy. But for the same amount of cholesterol lowering, the relative risk reduction from a cholesterol-lowering medicine is about the same. It's a little bit of a complicated concept, but if you start out at higher risk, the relative risk reduction gets magnified. That's the absolute risk, and that is much more tangibly related to benefit for a group of individuals. Okay. Now here, when you add a polygenic risk score, just like any other clinical risk factor, the risk goes up. But it turns out for the same amount of cholesterol lowering, the relative risk reduction for coronary artery disease, for cardiovascular disease, is even greater. So what that means is that further magnifies the absolute risk reduction, meaning in addition to helping us predict risk, it helps us identify those who are going to actually benefit from the preventive therapy, namely here cholesterol lowering with a statin, but that is actually translated to other cholesterol lowering medicines as well too, tools that we already have in our armament. And the evidence base is growing, is getting more compelling. Actually, the recent cholesterol guidelines, and these get released about every 5 to 10 years, but the latest actually just came out last month. And now, for the first time, incorporated genetics, incorporated a polygenic risk score into these guidelines. So these things are now starting to make way into a broader clinical practice. And, as a group that is interested in advancing the science, if this is going to be in clinical practice, it's very important for us that it's a valid test across a group of individuals. And this is where the All of Us research program comes in for us. Because we use the external data where there are tabulated individuals who have heart disease and not, and that's how we discover each of these gene regions. But we have to train the predictors in the data set that is most reflective of the patients that we see. There is really no other better data set than the All of Us research program. And we have the benefit of also having a biobank within our health system so that we can, in addition to doing all of the data analysis and really refining the best algorithm that works across the US, we can take yet another data set and say, okay, is that actually the case? And just have, another independent data set. And we do it, we can do it for multiple different conditions. This is actually 8 conditions. Coronary artery disease is one of them because it's the same underlying assay. It's just a mathematical exercise. And that's what this clinical report looks like. And this is something that we've launched within our health system, and any clinician in the US and actually outside the US as well can order this test. And it comes to patients as a spit kit. They send it back to the lab, and then they get a report that goes to them and their doctor that's valid for clinical use. So I'll wrap up here, and there'll be time for questions. And so, I'm excited that this score can help bridge key gaps in prevention. This is directly tied to the conundrums that I deal with, in younger patients. Younger, I mean, 30s to 50s, who will always be estimated at low risk by the tools that we use today. And a fraction will have familial hypercholesterolemia, but most of them do not. And I think this test will help us identify many who have high risk. It won't address all of them, but the bar is low because we're missing most of them today. And importantly, if we're going to use a predictor across a broad group of individuals, we have to make sure that it has been developed and refined in a broad group of individuals. And I think, as we continue to do larger studies, we can improve these polygenic risk scores. As I said, it's a single assay, and we can calculate for multiple different things. And then I think that core concept that I want to say is that we're using the genetics, an inherently a static factor, something that it by itself does not change. But the fact that so many different things influence the likelihood of chronic disease, especially cardiovascular disease, that knowledge actually allows us to change the trajectory when we recognize that early. Okay. And critically, I know many of you that are on are participants of All of Us. Thank you so much for your dedication and support, and then obviously for the staff for making these data available to researchers and clinicians like me. Thanks.
Wonderful, Pradeep. Thank you. That was fantastic. And thank you for making polygenic risk scores so approachable to a broad audience. I'm going to guess that there were folks in the audience today that really didn't appreciate this area of research and their implications for clinical care. We have about 8 or 9 minutes for questions, and I see some are coming in through the Q&A. Let me start off with one, since this what you spoke about was focused largely on genetics, but even in the early definition of risk factors, certainly the Framingham risk score in the 1940s or 50s or 60s did not have a genetic component. So help us understand how the polygenic risk, do you see it being put into the context of other risk factors? What's the future of risk prediction look like from your perspective?
Yeah, Jeff, you bring up an excellent point, is that risk prediction's got to be comprehensive. We have to use all of the factors related to us. In general, there are multiple different reasons why somebody might or might not get cardiovascular disease. So this is one test to influence overall global risk prediction. Now, interestingly, the Framingham risk score and now the newer iterations of scores that we use in clinical practice do not include family history, even though that's a signal we've known for over a century. The reason why is that family history is very complicated. It's individualized to the individual and their patient. And I'm spending most of my time trying to understand the person or the people who are not in the room who are affected. Is that related to the patient in front of me? Sometimes it may be related to similar risk factors. Maybe somebody smoked and maybe that's why they developed heart disease, or somebody developed breast cancer and didn't live long enough to develop cardiovascular disease. But it's really tough, to some extent we are guessing. This is a way for us to purely quantify the shared DNA in that. So that's a separate plug why this is information that is not currently captured in the risk scores. What we're working on is a framework to incorporate all of these factors together. So when doctors go in and plug in the numbers to predict risk and then say, okay, it's somebody sufficiently high risk that we need to do more, or do more evaluations, potentially recommend medicines. We need to be able to have a polygenic risk score cleanly come into that as well. And that is ongoing work, but that's important.
Thank you. There have been a couple of questions that have to do with genetic ancestry, and you alluded at the end of your talk to the importance of all of us data set to allow the genesis of the polygenic risk scores that you've developed. So let's talk about genetic ancestry and polygenic risk. Are all polygenic risk scores going to be applicable across a population? And how do you know when one is relevant to individuals of non-European ancestry or not? Tell us how you might approach that question.
Yeah, any predictor is going to perform best in a group of individuals similar to the group of individuals that it was trained on. The legacy of many of the original data sets, like the Framingham Heart Study, are largely Eurocentric. So the scores in general perform better in Eurocentric populations. That is also the legacy of most clinical risk predictors as well. As the data sets are getting more diverse, the improvement of the polygenic risk scores are only going up for other populations. There is one notable, interesting observation for polygenic risk scores, is that the performance in individuals of African ancestry are not yet getting close to European ancestry like the other populations. And there are many different reasons why that might be, and a lot of them are hypotheses. It's not specific to coronary artery disease, but I'll make 2 comments related to this. Is that one, when you deliver a report, you can incorporate features of ancestry so that the score that when is delivered to an individual accounts for the overall background differences in ancestry. So you can say for somebody with different ancestral backgrounds that this is high risk for this individual and this is high risk for somebody else. To some extent, we're incorporating that in the reporting. But that is actually an innovation here that we can do with the genetics, because other risk factors like lipids, like blood pressure, we know that the distributions of these are different across different groups of individuals, but the cutoffs are exactly the same. So this gives us an opportunity to know about the differences and actually incorporate so that we are more accurately representing the scores back. Now, separately, scientifically, why is there a difference? We think, or at least maybe I think, is that there might be more important differences or more important influences in cardiovascular disease for some populations. There are yet undefined interactions between the genetics and these other influences. And then separately, the polygenic risk scores actually do not cover all of the different types of genetic variants. For example, there are rarer genetic variants like familial hypercholesterolemia. And we have some unpublished work, at least as it relates to cholesterol, suggesting those rarer variants that are not necessarily familial hypercholesterolemia, but more common in individuals of African ancestry, actually might have a more important influence on traits like lipids as well. So this is quite interesting. Generally, big picture is that the limitation here is not whole genome sequencing. Like the costs continue to go down. It's all less than $100 to do a whole genome. The challenges here, and there will be continual challenges, is that we're continually learning about the human genome and interpreting. And we have to think about frameworks that, as we are learning, if they're impactful translations, how do we get them to patients? How do we have a system that continually learns as well, too, so that as we learn as a field, we can bring that back to patients?
Thank you. I probably time for one last question, and it relates to whether you think that underneath the polygenic risk scores, the 350 regions of the genome that you mentioned, there's opportunity for precision prevention. That is, a person with this particular set of weights in their score might be more likely to respond to diet, or somebody who might be more likely to respond to a particular drug or physical activity or yoga or something like that.
Yeah.
What do you think about that?
Yeah, those kinds of assessments are best done when you're analyzing within a clinical trial, because there's so many different reasons why people do yoga, why they choose particular diets. And the diets are, not just one particular food or one particular macronutrient. So most ideally, that assessment is done where there is kind of a balance between all of the other factors, and it's just purely that specific thing that they're doing. So what has been done, because most of the genetic analyses in completed clinical trials so far have been in cholesterol-lowering trials, but more are happening right now. But there is actually, from colleagues in Boston, they did something interesting where they only looked at a subset of the polygenic score for coronary artery disease. And they looked at the subset that seemed to influence the genes that were more relevant to the coronary arteries, the arteries where there is plaque buildup, the endothelial cells. And they just looked at that subset, not necessarily the best overall predictor for disease. However, they saw an even greater magnitude in the relative risk reduction. Just by looking at that subset, they kind of drowned out more of the noise, more of the other genetic factors that may have less relevance to cholesterol lowering, and were able to better isolate those who are going to benefit from that therapy. So that could, in theory, be done for others. It does require some domain expertise in just kind of subsetting these. However, now they're increasing generation of these larger cellular data sets where we can kind of look at these programs, these biological pathways and programs together to kind of subdivide. But that's very early days for things like that. Right now, it's anchored on predicting at the overall disease, hoping that it has relevance to the intervention. But now we're gaining more sophistication and prioritizing these things based on the intervention. That's what we want to get to for precision medicine.
Well, thank you, Pradeep. We've unfortunately run out of time, and we have more questions and discussion than we have time for today. So hopefully sometime we can get you back here. But it's been a great pleasure and an honor to have you give this keynote today. Thanks, everybody else, for joining us. Please complete the short survey after the session. And up next, we have two concurrent sessions, one on how life circumstances shape health, and the other on brain health, mental well-being, and recovery. Thanks again, everybody. Enjoy the rest of the Science Day.
Thank you.